Welcome to InfoCardia, where we aim to summarize landmark cardiac clinical trials in under 10 minutes. Today we will be discussing a trial related to atrial fibrillation, or AFib for short. Now, what is atrial fibrillation? It is the most common sustained arrhythmia worldwide, and it is a deviation from the normal sinus rhythm of the heart. Now, in atrial fibrillation, it is theorized that there are the development of these ectopic foci, which release electrical activity that may override the SA node. This electrical activity causes the atria to quiver or fibrillate in an irregular fashion, generally faster than normal. Some of these electrical impulses will travel through and make it to the ventricles, causing tachy or bradyarrhythmias. As you might imagine, this irregular beating of the heart leads to possible complications such as stasis, hypercoagulability, and irregularly fast beating of the heart, known as atrial fibrillation, with rapid ventricular response, or RVR, generally defined as a heart rate greater than 110. This can be seen here on this EKG, where we see a lack of P waves and a lack of sinus rhythm, indicating atrial fibrillation as the possible diagnosis. In addition, if we look at the QRS intervals, we see that they are irregular and irregularly spaced out, what we call irregularly irregular. And again, this is showing atrial fibrillation with RVR indicating the fast heart rate, with atrial fibrillation being the most common sustained cardiac arrhythmia worldwide and affecting millions of people. A lot of thought has gone into the management of this pathology. There are a few thoughts. One thought is to manage the rate of atrial fibrillation, generally aiming to maintain a heart rate under 110. This is done with agents such as beta blockers or calcium channel blockers, thereby preventing the patient from going into AFib with RVR. The other technique utilized is what we refer to as rhythm control. So cardioversion, whether electrical or pharmacological. Pharmacological cardioversion often utilizes medication such as amiodarone being one of the very common, even with its common side effects. And outside of this, other mechanisms used to control atrial fibrillation should the initial fail are things such as the Maze procedure, radiofrequency ablation, amongst others. One thing to keep in mind is, irregardless of rate or rhythm control, initial anticoagulation and possibly lifelong anticoagulation is indicated in the right patient. Common agents utilized to achieve this anticoagulation include warfarin, and now with the advent of DOACs, or dual oral anticoagulation. Having discussed atrial fibrillation in short, now we arrive at one of the first and largest trials, known as the Affirm Trial, or atrial fibrillation follow-up investigation of rhythm management. This was released in 2002. The question being asked was, amongst patients with atrial fibrillation and a high risk of stroke or death, what are the effects of rate control versus rhythm control on mortality? This was a large multi-center randomized controlled trial. What was the inclusion criteria? It was generally patients above the age of 65 with atrial fibrillation, generally high-risk patients with long-term treatment of AFib was warranted, and also these patients generally had other risk factors for stroke and death. What was the exclusion criteria for this trial? Well, any contraindication for anticoagulation, such as recent and significant brain bleeds, was an exclusion criteria. Other exclusion criteria included ineligibility to undergo the trial of 2 or more medications in either treatment strategy. And as we can see on this chart here, the average age of participants in both arms of the study was around 69 to 70 years of age, again excluding the younger population. As far as risk factors and comorbidities, these were fairly evenly distributed amongst the 2 arms, with p-values being less than 0.05, so no significant difference there. Next, we have this chart which illustrates the 2 strategies utilized in this trial, which we previously touched on. The first being rate control. For this trial specifically, the therapeutic target for heart rate at rest was set to less than 80 beats per minute, and during activity less than 110 beats per minute, which usually consisted of a 6-minute walk test. Medications utilized to achieve this rate control included beta blockers and digoxin being the most common, along with calcium channel blockers utilized as well. The other strategy for this study was rhythm control, which we touched on earlier. Antiarrhythmic agents were chosen by the treating physician. Per this chart, the most commonly utilized was amiodarone, keeping in mind its many side effects. An important factor to keep in mind is that patients were allowed to switch between rate and rhythm control arms. Another very important caveat was that of anticoagulation. While those on rate control maintained anticoagulation throughout the study, those in rhythm control, specifically patients that were able to maintain sinus rhythm for 4 consecutive plus weeks, were allowed to come off of anticoagulation. Additionally, while it was uncommon after the failure of at least 2 trials of either a rhythm control drug or a rate control drug, patients could be considered for non-pharmacological therapy such as radiofrequency ablation, maze procedure, and pacing techniques. Having said all this, what was the outcome of the trial? The primary outcome, looking at the 5-year mortality, showed no significant difference, with 25.9 versus 26.7 rate to rhythm control respectively, with a p-value less than 0.05, again indicating no clinical significance of a difference. Interestingly enough, other complications pointed out here did actually have an increased incidence in the rhythm control arm. These included torsades, PEA, and hospitalization. Again, we see here around the 2-year mark, there was a small divergence between the mortality in rate and rhythm control. However, the difference and p-value was less than 0.05, so again, no clinical significance. As with all studies, Affirm had its limitations, such as possible selection bias in patients with severe symptomatology who may have not been deemed candidates by physicians for a rate control strategy. The study was also not generalizable to the younger population and specifically included patients above the age of 65. Also, those with successful rhythm control could have their anticoagulation stopped. This may have introduced a bias in stroke and death outcomes, as this led towards less use of anticoagulation in the rhythm control group. In general, this seemed to imply that rate control should be the primary intervention in AFib. However, as we know, this was not the end-all be-all, with the release of another landmark trial known as the Early Treatment of Atrial Fibrillation for Stroke Prevention trial, also known as the East AFNet 4 trial, which we will discuss in the next episode.